Hi, everyone. We're just going to give a few more minutes for people to still join, and we'll start shortly.
Good afternoon to everybody from a warm and sunny Cape Town. So hello to Africa. And we do have a focus on Africa this afternoon and beyond the borders of just South Africa. So we are very privileged with what we are going to be able to do today. So I see we're now going to start with the preliminary slides. So this afternoon, the topic is delayed diagnosis of multiple myeloma, an African perspective. So it's a talk that's very near to our hearts, and we really look forward to share this afternoon with you and to hopefully share also across the borders with Zimbabweans, with Namibians, and further afield. So I am from UCT, a warm Cape Town. I just want to actually close my door here because I think sound is traveling in my office. So just a moment. There you are. Okay, so I'm back. So we all know the housekeeping notes that the recordings can be found back on our website. And that we love questions and love interaction. So please put your questions in the chat box. Please ask questions during the meeting at the appropriate times and afterwards. And yeah, let us know what we can do to make things better. CPD points is an important part of this meeting. And again, you know that you have to enter that number correctly to get your CPD points, but you can always inquire if there's a problem and speak to admin at bloodisa.org.za. So let's see. Yeah, if you want to join, here's a QR code and get onto the mailing list. And yeah, keep giving us feedback to keep it a meeting that is a marketplace of minds, a marketplace of hearts. Let's say engaging place of hearts and of best care for our patients. So let's continue. Yeah, so this is us, who's doing the admin. And next week we have a most wonderful speaker who will delight us all, Prof. Adam Bagg, until recently from the University of Pennsylvania, UPenn. And he is going to speak about a fantastic topic, eosinophilia, entities and everything else. And he is definitely going to keep us laughing as we're learning. So it will be a session not to be missed. So the topic today is the delayed diagnosis of multiple myeloma. And we have three wonderful, wonderful speakers. So, and I'm going to not waste much time today on lots of introductions, but we have people really on the ground and from 3 different countries. We've got Dr. Ryan Aylward, who is a postdoctoral research fellow in our division at this stage for this year. And he is working on the diagnostic pathway of people referred with multiple myeloma and looking at all the routinely collected data and how to put this data together to actually give us a picture of what doctors did before the patients were diagnosed, and what we can learn from it, how to do it better. And if medicine hadn't worked out, he would be there's now a little bit of a, what would you have been? Tell us, Ryan, because I can't read it on the slide. What would you have done?
It says I would have been foraging in the mountains, so I would have been a mountain goat.
That's wonderful. I'm so happy I didn't try to guess what was written there, because a mountain forager is now the last thing that I would have said, but isn't that wonderful? So what you actually say is you like to walk, but you want to stop and enjoy. That's actually what you're saying. You will smell the roses. That's good. And yeah, so let's continue to Dr. Moses Chatambutsa. So Moses is very, very well known to us all. He makes an impression, deep impression on everybody meeting him, with his incredibly infectious intelligence, interest, always looking for the best, trying to do the best, this energy around him. And he is our very, very valued colleague from Zimbabwe, who is working in I'm going to do this good. Pariren Hospital. Was that okay? Or did I do very badly, Moses?
You did very well. You did very well.
You're very kind today. I love that. So, yeah, so you are working hard at good service delivery and teaching at the University of Zimbabwe, as well as research activities in multiple myeloma, hemophilia, transfusion medicine, and lymphoma. And your passion is to improve hematology care exactly the way, you've been doing this weekend with the International Myeloma Society meeting, and also today, collaboration and all across Africa, really getting all of Africa involved. Okay, so next slide. Yeah, so there's Dr. Kudakwashe Simba, known to us as Dr. Simba, and he is an old friend of our unit. He is one of the brilliant young clinic physicians that came to specialize with us, and it's been an enormous joy to have him with us. His infectious ease of just moving through everything that's perhaps difficult and daunting with good humor and with real attention to detail and care of all the patients. That's what he's now also doing in Lady Boamba Private Hospital in Windhoek. And he's also consulting and admitting patients in other private hospitals. And Simba, as far as I know, you also are working with the Windhoek, the university hospital teaching. Is that correct? Good afternoon, Simba. So I won't bother him now, but so also holding together the university, the hematology input at the academic hospital in Windhoek. Okay, so next will then be, let's see, time for Ryan to start. So.
Good afternoon, everyone. I will be presenting a lot of data that I presented at IMS over the weekend. So if you did attend, my apologies. There are a few new things as well, but also a good opportunity to rediscuss if you didn't get a chance to over the weekend. So I'll be presenting 2 cases, as well as some original research that I've been involved with. The topic being pre-diagnostic routine lab testing patterns in people with multiple myeloma, referred to our unit. So the first case is Mr. Confucius, and I did receive permission to use his picture. He is 61 years old and he's living in Cape Town. He has cardiovascular comorbidities and he's HIV negative. We later learned from his family that he had a history of many years of back pain and nosebleeds, but we didn't know this at the time. He presented initially to a district hospital with an upper GI bleed with a very low HB. Complicated by acute kidney injury and proteinuria, the normal calcium, corrected calcium, a reduced albumin, and his hematinics were replete. He was then transferred to a regional hospital and also transfused red blood cells, where he was found on gastroscopy to have what looked like gastritis, and that was confirmed histologically as chronic gastritis. So he was assumed to have a low HB because of chronic GI bleeding, and he was started on appropriate therapy. While he was admitted, he developed septic shock secondary to pneumonia. He required vasopressors. His acute kidney injury worsened. He became exceptionally delirious and had ischemic hepatitis. His laboratory tests at that time, when he decompensated, showed a raised total protein, a reduced albumin with a wide globulin gap. And based on those results, a SPEP was performed and a monoclonal was found at 71 grams per liter. He then came to us, or was referred to us with myeloma, and we admitted him under hematology, at which time he was exceptionally delirious, hence his name. The second case is a young female who presented with seizures, weakness, and back pain to her local district hospital. It was at this admission that she was diagnosed with HIV. She was previously well. She was found on CSF examination to have pneumococcal meningitis. She had a negative TB workup, including sputum gene experts and CSF culture. And she was treated for her pneumococcal meningitis as appropriate, and she was initiated on antiretroviral therapy. During her admission, her HB was low at 9.9. She had acute kidney injury. She also had a raised total protein and a reduced albumin. And further on, she was then well and discharged home, but represented about 8 months thereafter with ongoing back pain to orthopedics, who undertook a CT spine, which demonstrated vertebral compression fractures and a lytic lesion in the pelvis. She had a prolonged ESR. And based on those lytic lesions, I'm assuming that prompted a urine-free light chain quantification, which showed monoclonal free light chains on immunofixation. Unfortunately, as you know, it takes a while for these results to become available. So while she was admitted and the fact that she had a urine lamb that was positive, empiric anti-TB therapy was commenced. For those who don't know, urine lamb is a point-of-care TB test that is especially good in people with very low CD4 counts. She was then discharged and represented another 2 months later with medicine, and that is when I assume the diagnosis was made based on this previous results 2 months later. So in summary of the two cases, the first case, total protein, was probably accidentally requested as part of a routine panel of investigations in someone who was very unwell. It doesn't seem to me that myeloma was an initial consideration, especially because there was a competing diagnosis or explanation for the anemia. In the second case, a total protein was requested and it was abnormal. But unfortunately, it doesn't look like anyone recognized the significance of the wide globulin gap, and it was not acted upon. Even though monoclonal was demonstrated either the healthcare provider or the patient did not follow up for that result to become manifest. And of course, a TB diagnosis, often in our setting, is the scapegoat for any unexplained symptom complex, really. So the take-home message here is really that an elevated total protein was the clue in both patients, and potentially an early diagnosis of myeloma may have been made if this test is requested, interpreted, and further investigated. It's at this time that I would like to ask Nicola to run a poll for us. It's a very quick 2 questions, and we can take the results to discussion at the end. So this is a head-to-head fight in the ring of total protein versus the gamma globulin gap. And the first question is, which do you think should be the initial screening blood test for someone who you think may have multiple myeloma? Would it be the total protein or the globulin gap? And secondly, what do you consider a raised globulin gap?
Is it working for everybody? Because I don't really, am I not supposed to answer this question? Looks like
We would love to know your opinion, Estelle. I can see movement.
But I don't seem to be able to answer. It seems to think that I don't need to answer. Anyway, then we'll hear the answers of the rest. It's coming.
I'll continue in the meantime, but please do complete the poll. So the background really on the back of those 2 case presentations is that the total protein could potentially be a good and inexpensive surrogate for a protein electrophoresis in resource-constrained settings. And earlier testing of total protein, and in addition to hemoglobin, creatinine, and calcium in the right clinical setting may expedite myeloma diagnosis. So the aim of this original research was to try and understand how healthcare providers use and act on these tests pre-diagnosis of myeloma. Obviously, all the patients that we have access to already have myeloma, so we only know about those who were confirmed to have myeloma, not the ones that did not have confirmed myeloma. The methods of the study included all consecutive patients with myeloma referred to us at Ridderskier from 2017 to mid-2024. And data collection included laboratory and facility encounter data, which was made available through the National Health Laboratory Service, as well as a health information exchange, which is unique to our province. We're very lucky to have the Provincial Health Data Center, which is able to provide data on all encounters for everyone in the province, because our folder numbers are universal across the province. Laboratory tests that were recorded were the hemoglobin, creatinine, calcium, and albumin, as well as supportive testing in the form of a protein electrophoresis, free light chain, or immunofixation. Here are some results. So we have available to us about 150 patients, the mean age of 58, about 50% female sex, 12% were HIV positive, and 19% had an unrecorded HIV test. The prevalence of HIV in the Western Cape is about 12%, so that is in keeping with the general population. About 15% presented to us with spinal cord compression, and about half had a recorded history of back pain. Most, this is supposed to be ECOG more than 3, was about 30%, I think, if I remember correctly. And each person had a median of 10 visits before the diagnosis was made. We consider diagnosis to be the date of the bone marrow biopsy, although all of this happened during an index presentation that were very much in days of each other. Here are the characteristics of the total proteins that were available to us. Out of the 152 patients, or in total nearly 1,800 facility visits, there were 208 total protein tests, and about half of the total protein tests were at the time of SPEP, because the SPEP provides a total protein result. On average, about a third had 2 total protein results available, and 2/3 had 1 total protein available, with a very abnormal median in both cases, and on average about 4 months between the first and the second total protein, and 76% were abnormal, and that abnormal is greater than the lab reference range of 78 grams per liter. The globulin gap in HIV positive, negative, and untested individuals is shown, and you will see that those who did not have HIV, their globulin gap was very similar to those who were HIV negative, so these untested individuals were probably HIV negative as well. But you can see there's a gap between the two values, 83 grams in someone who was HIV positive on average, and 60 grams in someone who's HIV negative. These are scatter plots which show the average, the concentrations of creatinine, calcium, and hemoglobin before diagnosis in time. So time 0 is the time of total protein, in fact, not the time of diagnosis. And the dashed lines show the upper or lower limit of normal, respectively, for the different tests. And what you'll notice firstly is that when the result was available, it was highly abnormal. And the second observation being that very early on in the course of, pre-diagnosis, there are very sparse results available up until about 2 months before the total protein was requested, by which time many more results were available and they were grossly abnormal. And in the box, in the table at the bottom as well, we can see that the hemoglobin was tested in about 22% of visits, and 91% of results were abnormal. Abnormality being below the reference range for males and females respectively. The creatinine was performed in 26% of visits, and 54% were abnormal. The calcium was rarely tested until the very end, pre-diagnosis, and 56% were abnormal. These are Kaplan-Meier graphs showing the time from the first abnormal total protein, assuming that an abnormal total protein should trigger a protein electrophoresis, for example. And anemia, kidney dysfunction, and hypercalcemia here are defined by CRAB criteria, not by the laboratory reference range. I stand to be corrected. I apologize. These are all lab reference range definitions. So what you will appreciate is that for once someone has anemia or kidney dysfunction, it takes very long, in fact, for everyone to have a total protein, although the majority will have a total protein tested within the first 3 months or so. But for hypercalcemia in particular, firstly, this test is not very commonly done, so it's probably only done in someone who is very unwell. But once it is done, a total protein follows very quickly thereafter. This is a bar graph of the proportion of CRAB features that were evident on laboratory testing before diagnosis. So the x-axis is months before diagnosis. And the CRAB, the bone part of the CRAB criteria here is proxied by the dispensing of analgesia as a proxy of bone involvement. With time in the future, I hope to try and strengthen the evidence for bone involvement without having evidence or documentation of lytic lesions. And you'll notice that the majority, even many months before diagnosis, had at least 2 CRAB criteria evident. This is another Kaplan-Meier graph showing the time or the probability of having a supportive test being a protein electrophoresis or free light chain assessment from the first abnormal total protein. And you'll notice quite a sharp drop there, which indicates that people, once a total protein is abnormal and recognized, a supportive test follows very quickly thereafter. Although the graph does extend quite far in time, you will notice that in the risk table below that there are very few numbers, and so I would not overinterpret that duration of time as being prolonged. So this is my Streetwise 2. The first takeaway that I would like to stress is that total protein in routine labs are often only requested very late in the pre-diagnosis, in the diagnostic pathway. And this is probably very likely when someone presents very acutely unwell, they're being admitted, and that is when these tests and myeloma are being diagnosed. And the second takeaway is that when these tests are done, they are already grossly abnormal. So there shouldn't really be an excuse not to follow up or at least investigate appropriately an abnormal result or anemia or kidney dysfunction, for example. And the message really being is that we need to try and advocate for early testing in the right clinical setting and correct interpretation and recognition. So, for example, if someone presents to primary care with back pain, total protein and a few other basic tests should really be the minimum tests, laboratory tests that are offered. And although not an important takeaway for those working in hematology, because we see patients already with established myeloma and complications thereof, but really that we should be spreading this kind of message to primary care physicians when we interact with them. And finally, I would like to acknowledge a few co-authors in this work and my postdoc supervisors, Estelle and Vernon, as well as the Bristol Myers Squibb Foundation for funding my work and getting these results spread across the country. Thank you very much.
This is lovely. I really enjoyed the talk, Ryan. Are you still with us? Because I think we're going to have a bit of a chat and not rush through. And let me see. Yeah, I think you're not. Moses, do you also agree that we could have a bit of a few moments here to just answer questions from on this talk? And then after you and Simbab's talk, we can actually have questions more specific to those talks. I don't know what your opinion is, Moses. Just
yeah, I think that's correct. And maybe I can pose my question to say, what proportion of the multiple myeloma patients in your cohort presented with an elevated total protein?
We can about
Ryan,
70%.
but I also ask and keep asking.
About 76% had an abnormal total protein. And since most total proteins were about half were done at that index admission, we can say with some certainty that the majority were abnormal.
Moses, I don't know what your experience is. It would be nice to see what you have done, but my question also to Ryan would be, What about, I don't know, for some reason, this poll is coming up all the time on my screen. Do I do something wrong? Anyway.
No, Estelle, I'm showing the results, but
Oh,
please
sorry,
ignore.
are you showing? Okay, sorry, then I'll leave it because it keeps popping up. But we can talk about that thing. I would like to know if the very few proteins that were done, but that's to give away Ryan's is revealing of secrets to us, is I would want to know the total proteins that were done a month before diagnosis. Moses, don't you agree? I would want to know if they actually give you exactly the same information. Are they also raised? I would go, let me guess, and I'd love to know what others think, Jacques and others. I would guess that it would also be raised a year before and 18 months before, when the patient already start complaining. Because, and that's the big caveat that I do think is very important to mention for the young physicians among us, obviously only about 80% of myelomas have a raised total protein. So 20% of myelomas will not be picked up, especially in our environment where the albumin is often lower at diagnosis. We definitely have a problem that you can't rule it out. It's not a rule out test if the total protein is normal. It's only a rule in test to go do further, as Ryan calls it, supportive testing. So I don't know what your response to that is, Ryan, and if anybody else has something to say about that, please put up your hands that we can talk about it. Perhaps Ryan first, your response. Do you have an idea, an inkling?
Well, I don't have a number on the tip of my tongue, but according to the Kaplan-Meier graph that I showed, the last one, you'll see that once a total protein was abnormal, it rapidly resulted in a supportive test. So I assume that most tests were abnormal at the very end, and I can say that about 76% were abnormal in total. Whether or not that was the test that was done a month before diagnosis, I can't tell you right now. But I assume that they were at least at abnormal months in advance.
That's fine. Any other opinion on total protein in this setting? I see that Jacques has asked a question, which I think is quite relevant. Let's just go to it. Would it not be worthwhile to look at total protein and the globulin gap in general medicine population to determine the sensitivity and specificity of the tests? And I don't know if Caroline is here, but Caroline, is that not exactly what we were talking about? We agree. It would be worthwhile. And we think it should happen. What do you say, Caroline?
Hi, Estelle. Thanks. If I can quickly say something, to be great. Yeah. So as Estelle knows, I'm interested in sort of a very similar research question, in the sense that we all feel the same way about patients being delayed unnecessarily when there are sort of clear signals early on to sort of support doing protein electrophoresis testing. So yeah, I think looking at a control population is important, because when I was sort of looking at the data or the literature surrounding this topic, there are obviously other comorbidities that can affect one's globulin gap. And some of those are quite common in the general population. So things like liver disease with cirrhosis, or inflammatory conditions, or COPD exacerbations, which probably not going to elevate it to this degree, but polyclonal increases in gamma globulin.
I don't agree that it's common. How many liver cirrhosis do you see every day?
Yeah, but in a sort of a general medicine, more of a general medicine setting. So I know this. I don't think that was the focus of this PhD, but it would be perhaps useful to determine the sensitivity of doing this, whether, what other illnesses can also elevate your globulin fraction.
I agree that was we were wanting to know what else would do it, but I do not really think that we are ever going to be in danger of overdiagnosing myeloma, because the moment you see a high total protein, you're actually honor bound to do a SPEP, agreed? And that's one of the problems. Nobody does it. But a high total protein is absolutely an indication for an SPEP. There is just no reason not to do it. And then you will very quickly see if there's something monoclonal or if it's polyclonal, agreed? And if it's polyclonal, then you can start thinking, oh, but is this something else? What would this be? Chronic inflammation, liver disease, those kind of things. And I would think for a liver disease, the pattern should also be very clear. And it would probably be very clear that there's that, what do they call it? The gamma
bridging,
gamma bridging and so on. So that's why an SPEP, I think, I would want to make the point, we should actually have a poll on that, Ryan. You should quickly make a poll. I would want to say, I want to ask the audience, don't you agree that every sick patient needs a full biochemistry? That we must stop doing only 5 tests, because I think it's very dangerous in a very sick patient to only do a few tests, because then the best of us will forget what we have not done and we will think it's normal. Isn't that so? I will forget if I didn't do certain tests. I would not, if it's not in my first baseline, I will forget that I haven't tested the glucose in the urine. I will forget that I haven't tested an LDH. It will just, I will think it has been normal. Is that not true? I wish we could have a poll on that, because I do think that we should do more tests.
Give me a second, I can.
Every sick patient should get a full chemistry and a peripheral smear, and we feel strongly about that. And I think it's false. The stuff that Ryan's work will show is that it's false economy to not do proper testing in sick people. Because have you told us how many times these patients have actually come in, Ryan, in the 12 months before diagnosis, or 18 months? Have you given us a median of being seen with complaints?
There were about average 10 visits per person in the 2 years before diagnosis. Whether or not that was with symptoms of myeloma, I cannot say. And that is work that I will do in the future.
Yeah, so I think Ryan has the idea that it probably is with symptoms, because he excluded visits like where there was only medication given and so on. So let's say, even if it's 5 times or 8 times that people came with, it's probably 10 times in the previous. That's a lot of healthcare visits. Think of all the money, all the time of the doctor, all the time of the nurses. It's a lot of contact, and it must cost a lot of money to see patients in those circumstances. And I just want to say, I am not a superhuman. I'm not a super person. I'm just a normal person, and I can't see what the patient's diagnosis is by looking at him. I definitely need to have proper supporting blood tests, and I need to have them all. Simba, you have something to add? Just
yeah. So I mean, thank you very much for giving me such a chance. I think it's been a long time. I've been on a hiatus in Namibia here, but anyway, I think this is very important. I think this topic is very, very crucial, because it's a low-hanging fruit. The issue of the albumin protein differential. Every time when I see a myeloma patient, especially with the medical officers, I try to hammer it to say, look, when you see this, please think of myeloma, because if one looks at it, you tend to see that the patients were coming in like what the research showed so many times. And if you go back, you will see that that protein differential was there for quite a long time. And by the time we see these patients, honestly, I mean, for some of us with limited resources, it's, they have got bone disease, they've got, they are on crutches, some of them are on, wheelchairs and stuff like that. So I feel like if you look at the economic costs of doing an LFT, to be honest with you, it's about 200 or 300. than to treat a patient and then you're doing radiotherapy, mapping, and all that. So if you are looking at the numbers needed to treat, I think doing an LFT on patients that are sick, I think to me it will probably reduce the costs. I don't know. Probably I'm biased with with what I do, but I think physicians, because I also do a bit of physician work, probably half of my work, but I think that it's important because it really saves lives if we do that. That's all I have.
Thank you, Simba. On that note, we agree. I see there is 8% who don't agree that we should do these. I think the question is perfectly put, but I think if we ask those disagreeing, every sick admitted patient, who's not absolutely clear what's wrong, but still, I will maintain that it may be somebody coming in with something totally different and may actually also have, say, renal failure, or actually also have something else happening to them. I would like to have those tests, would love to have them. Is it possible? So let's continue with Moses Tatambutsa. Moses, we are very honored to have you with us and very honored to have you as part of our fraternity, our big fellowship of treaters in sub-Saharan Africa. So let's continue with your talk.
Thanks, Estelle. I think two of my registrars requested to present on this platform on our work in this myeloma research. So Dr. Msao and Dr. Guta are going to present. I don't know whether they can share their presentation from there, or I need to share from this side.
I think Nicola can help us now. I'm not sorry if I may be missing something. Sorry, you can just share in the normal way. There you are. Perfect. Good afternoon, Sao. It's great to see you on the platform. So I look forward to see what you're going to share. And also, Dr. Guta, great to see you.
Great to see you here. Afternoon, Prof. Thank you for the opportunity. Thank you, Dr. Guta. So I will talk about delayed diagnosis of multiple myeloma as a Zimbabwean perspective. Just to give a brief overview of our country, this is a country of about 50 million people, divided into 10 provinces with eight provincial hospitals. These are secondary level hospitals, one per province, except for Harare and Bulawayo, where there are 5 tertiary level hospitals. 3 are in Harare and 2 are in Bulawayo. So as far as diagnostic capabilities is concerned, Paranyatwa is the greater part of the diagnostic machinery, which includes a serum protein electrophoresis machine, the ability to do bone marrow aspirates and trephines, plasmorphology and immunohistochemistry, and we're in the process of setting up flow cytometry. Currently, we do not have fish available. We do have running flow cytometry in the private, but this is just in Harare. And in Bulawayo, we have one center that can do bone marrow aspirates, trephine morphology, but there is no fish and no flow cytometry. The other tertiary hospitals, they lack the diagnostic capabilities to make a diagnosis of multiple myeloma. And hematology services, as far as personnel is concerned, Paranyatwa Hospital, which is in Harare, which happens to be a training, University of Zimbabwe training hospital has got 3 hematologists and 9 registrars in training. We also do have 1 hematologist in Harare who's in private. We have 1 hematologist in Bulawayo. So in government, there are a total of 4 hematologists covering the whole country. We have received funding from BMSF, and with this funding, we managed to train medical officers in 3 provinces. That is in Harare, those other 2 central hospitals that are not do not have hematologists, and in Midlands and in Bulawayo. So what tends to happen with these provinces that have been trained to do bone marrow aspirates and refine, they send their samples for bone marrow analysis at Pararinyatwa, and they also sent their blood samples for serum protein electrophoresis. So prior to the Bristol Myers Squibb Foundation funding, that is prior to April 2022, we had a total of 93 patients recorded that had a diagnosis of multiple myeloma. And between April 2022 and March 2024, within these 2 years, we managed to make a diagnosis of 197 new myeloma cases. Unfortunately, most of these patients, they were late diagnosis, as shown by the following analysis. To try and characterize our patients, we did a retrospective analysis at the end of the Bristol Myers Foundation funding. This one was entitled "The Prevalence of Multiple Myeloma Among Patients Referred for Screening to the Hematology Unit at Pararinyatwa Hospital." So this was just looking at the patients who were seen at Pari and who were screened for myeloma and subsequently diagnosed with multiple myeloma. So the aim was to determine the prevalence and to analyze the clinical pathologic characteristics of those diagnosed with multiple myeloma. So what we found is at Pari, 134 patients were referred to the hematologist, to the hematology unit, and 86 patients of those 134 had a diagnosis of multiple myeloma, which put the prevalence at 64%. And the median age of those that were referred for screening was 62, with an interquartile range that was between 50 and 71. And the demographic characteristic of patients who had myeloma, in line with the general trend, there were more males than females, and the median age at diagnosis was 62. And most of the patients were about 40, with 54% of those patients being above 60 years. And the clinical characteristics, the greater chunk of the patients had bone pathologies, with 72% of the patients having osteolytic lesions and 52% with fractures. Anemia also contributed a greater proportion of the patients, with the 68% of the patients, followed by hypercalcemia and renal failure. Of note, 23% of the patients were HIV infected. It is disheartening to note that most of the patients were diagnosed late, with 74% of the patients having an echo between 3 and 4. And the patient outcome, so of the 86 patients that had multiple myeloma, 54 of them died, which is 62.8% of those patients. And 37.2 of the patients were still alive. So we did another study to try and analyze and look into why most of these patients were dying. And I'll hand over this time to Dr. Guta.
Thank you, Dr. Msao. So we entitled this determinants of early mortality in patients with newly diagnosed multiple myeloma at a tertiary hospital in Zimbabwe. So we were just looking at the patients who had parirenyatwa of all the 197 that were said. So why we chose this study, we realized that early death of patients with newly diagnosed multiple myeloma was a significant observation in the hematology ward in the hospital. And we thought that understanding the factors that were associated with early mortality was important so that we can minimize early death. So a retrospective study was done on the records of those patients who were diagnosed between April 22 and March 2024. And luckily we had the Red Cap platform, which is being hosted by the UCT that we are using to capture our patients. So we use the Red Cap registry. And we defined our early death as death within the first 30 days of diagnosis. So aim was to determine the demographic features and also elaborate the factors associated with early death within 30 days of diagnosis. The results show we managed to analyze about 86 patients. These were the total number of patients that were diagnosed with multiple myeloma, new cases over the 2 years at the central hospital. And a total of 40 patients out of the 86 had died in the first 30 days of diagnosis, which is about 46.5%, an alarming figure. And of these patients, 24 of them, they would have died by day 14. And about 8.6% would die within the first 7 days. We noted that the most common cause of death was related to renal impairment, about 42.5% of the patients. And advanced disease caused about death in about 25% of patients, and infection was the third cause. So this is a graph just trying to show the distribution of the causes. So most of the patients were secondary to renal impairment. Advanced disease, it was difficult to define what advanced disease was, but this was like a combination of factors. If we saw a patient with 3 or more end organ damage features, and then we just put them on advanced disease, say fracture together with severe anemia and maybe renal impairment. So renal impairment being number one, we realized that about 76% of those patients that had renal impairment in the north, they were noted to say there were no inadequate resources for hemodialysis. Like they would say there's no catheter to be inserted, or maybe the renal unit is fully booked. In about 17% of the patients, there was no information mentioned about dialysis. Only 2 patients had a trial of dialysis, but unfortunately they demised. So we also looked at the other laboratory and clinical features of these patients that died within the first 30 days. Some of the parameters were significant, like age. Most of the patients that were above 65, for those above 65, 22 of them, 22 out of 37, which was 59%, they were died in the first 30 days with a p-value of 0.03, and this was significant. Gender was not quite significant. Infection, the level of the hemoglobin, they were not so significant parameters to say if someone has got a low hemoglobin or is female, they would die in the first 30 days. Having a very high calcium was also associated with early mortality, as we saw that most of the patients with a calcium more than 2.75, about 69% of them by day 30, they would have died. Maybe because it was also contributed to the renal impairment and also the unavailability of dialysis facilities. Eco performance status was not very significant as a factor associated with early mortality. The creatinine level was quite significant, as we noted that most of the patients with the creatinine above normal, they died in the first 30 days. A very high LDH and was also associated with early death. However, presence of comorbidities and albumin were not significant. So, in conclusion, we realized that despite the increased multiple myeloma diagnosis that happened, that is happening in the country, patients are presenting late, and unfortunately, most of them are dying within a month of receiving a diagnosis. And we are still having ongoing awareness and training, and we think having more hematologists in the country is quite essential. There are a few limitations maybe to the study because it was a retrospective study and there was a lot of missing data on some parameters on the patients, and also some limited investigations that are offered to the patients. If you can see, I didn't even report on the international stratification system or even the RIPSS because we don't have beta-2 microglobin. We can't do FISH for the bad cytogenetics. So we didn't report on that because we have limited investigations in the country. I would like to acknowledge all the doctors in our unit and the nursing staff and the university also, and also the supervisors that were guiding us, Dr. Moses, Professor Takana, and Dr. Maboreke, and also Bristol Mayor Squibb Foundation, which funded this this study that we had. I will leave this time for discussions. Back to Dr. Chatamuza to lead.
Yeah, thank you. And Moses, yes, let's take it away. Brilliant talks for you, Lloyd and Gita. Thank you.
Thank
No,
you.
thank you so much. Yeah. Lloyd and Gilta and the whole team behind the scenes. They are there, some of the registrars, they're on the platform. Yeah, so that's the data from our side. The good thing from the BMSF funded project is we managed to spread the message across the country to say there is a disease called myeloma. It presents like this, the ordinary crepe, and kindly refer all the patients that you're suspecting to have myeloma. And yes, people responded, but unfortunately, a lot of the patients were presenting quite late. And unfortunately, there was high mortality. And now our drive, especially after also listening to Ryan, is to try to actually maybe hopefully have a way of looking at these at the lab data and try to make sure that we see those with a high total protein. We look for those, we hunt for those patients. We do the STEP and actually try to have those patients referred early so that the mortality or the patient outcomes are better. Are there any questions for my team?
Yes, let's see. What I can say is I see Jacques and Caroline has already said they would like to work with Blood SA on these pearls or these pointers. We really invite everybody who would like to work with us. I do agree that we must be very clear, very accurate when we communicate, and we must be very simple, like a cartoon, you know, we must be Flintstones, not Dostoevsky. So, for example, as Ryan has shown, and as we all know, you can't say that total protein is a rule-in test for myeloma. well, it's a rule in, but it's not ruling out. So there is that kind of complexity will have to be made very, very simple for doctors, that they don't go do a total protein and refuse to do a SPEP in a patient who actually has myeloma, because we've taught them not to do it. I just think that's one of the things that's important. And then this whole approach and this whole thing of what type of tests should people get and what can we miss if we don't do tests. Just from my side, I think it's very important that doctors understand that in a patient with it's clinical approach, and it's for all of us, it's tricky. You get a elderly patient with heart failure with a tachycardia, and you think it's just heart failure. Well, perhaps you should sometimes do the thyroid functions, because actually the heart failure may actually be a thyrotoxicosis. So these are the kind of things which we can't teach people perfect pathways, but can we together work and to try and do it as well as possible, as good as we can? So who agrees and who wants to weigh in? Before we get to Simba, we do still have some time, but we would also like to hear Simba's experiences, unless Moses, let's see if there's some responses. Otherwise, we can go to Simba and then we can have a discussion. Well, Simba's actually chatting. So Simba, I think you can tell us what you think, and then you can also, while you're busy, you can start sharing your talk, and we can take it from there and have a final discussion at the end. Okay.
Okay, so I think firstly I would like to thank the team from Zimbabwe with their very, very extensive presentation. I think this is very important, especially for me, somebody who trained in Zimbabwe, that look, yeah, myeloma is a big problem, and unfortunately the exposure, especially during undergraduate training, it's not that much. And we see the challenges since we are the ones who are involved in treating these patients. So yeah, I would like to say, thank you very much for giving us this information. It's very important to see what others are doing, and really, I would like to say, you guys are doing an excellent job in this challenging environment, and I think you should keep it up. So without further ado, I will share my slide. So let me see. I need to share the screen, and then I'll put on slideshow. Not now. Okay. All right. Can everybody see my slide?
I think we can see it.
Okay.
Yeah, it's your slide. Yeah.
Okay, that's my slide. Let me see. Okay. Okay. So I think I was a bit ahead. All right. So I'm just going to talk about a Namibian perspective. Unfortunately, I don't have data to present, but I'll try to present the environment that I'm working in, so that people can understand the challenges that I'm having. I'm lucky that I work both in private and public sector, so basically I've got a bit of a view of what we have. Okay, so just to give you the gravity of the situation. So we recently had a census in 2023, and the population is now at about 3 million. We've got one pediatric oncologist, both in state and private, and then we've got 2 hematopathologists in private. This is at PathCare. In the public sector, unfortunately, we don't have a hematopathologist, and this is 85% of the population. So, and then there is one clinical hematologist in private and, part-time volunteer state. So that's me there trying to see how I can, sort out stuff. So just to show you on the left there, you've got Namibia. And you can see that this is it's probably, I think, the third most sparse country in the world. I think the one country that is sparse is Mongolia, I think so. And I've forgotten the other country, probably Canada. But you can see that there is huge geographical disparities here. I'll give you an example. A patient from Katima Mililo to Windhoek, it's about 1,200 kilometers. And because of this, one tends to see that there's delay to treatment, delay to diagnosis. And as we know, this has got impact on treatment. So the other issue is the resource allocation. So we know about the historical inequalities in the country. So what it has done, that we've got centralization of anything that needs to be done in Namibia. One tends to see that in Windhoek, that's where you see the specialists. In Windhoek, that's where you have most of the services there. So this has got a huge impact on the outcomes of treatment, like any other country. Okay, so what I would do here is I'll just give you a clinical experience and challenges in Namibia. So this is a 46-year-old male patient with an IgG kappa multiple myeloma, transplant eligible, who presented with severe back pain for 1 week on a Friday afternoon. So in the public sector, this is what will happen. So usually the patient is seen by internal medicine and hemo-oncology is consulted. That's if people think about it. And the patient, will advise them to start on steroids and supportive treatment. And then radio-oncology is consulted. Usually this is when heme-onc is involved. So the way that the system is, there is no clinical hematology department on its own. So it's a hemato-oncology department, and the general hematology department is at another state hospital. So there isn't a general hematology department per se, but I just try to also assist. So usually what happens is that once radio oncology is consulted, then a motivational letter is sent in private. And usually this is done on working days. And, planning is done the next day if you are lucky. Then radiotherapy is done probably, 4 or 5 days after. So after a week or two, we start the patient on cyclophosphamide and dexamethasone. And then the patient then achieved a VGPR. And because of limited resources, I'll talk about them. Treatment is continued. And once CRI is achieved, then treatment is stopped. So in the private sector, this is what happens. Usually I get consulted, patient, we start on steroids, and then therapy referred to my colleagues, the radio-oncologists. And usually we try to make the emergency radiotherapy as soon as possible. And then we send a motivation to SAOC. So usually in about a few days, we start VCD. And the patient then achieved an MRD negative by flow at 4 months. And then we motivate for an auto stem cell transplant, which is done in South Africa. And then after 6 months, we offer MEO 200. And this, if the patient is high risk, we can consider VCD reconsolidation, and then we give maintenance lenalidomide for 2 years. So, right, so this is where the challenge is. In the public sector, we are still in the dark ages. We're using drugs of the 1970s and early 80s. We've got melphalan, cyclophosphamide, we've got prednisolone, dexamethasone. We've no access to auto stem cell transplant, unfortunately. In the private sector, I call it the utopia, the land of plenty. I can juggle a bit. We've got cyclophosphamide, melphalan, we've got lenalidomide, pomalidomide, bortezomib, carfilzomib, ixazomib, you name it. When push comes to shove, bendamustine, those that are transplant ineligible who have relapsed, dexamethasone, prednisone. If the medical aid is quite strong enough, or if it is a government medical aid, we can offer auto stem cell transplant in South Africa. So, there is a bit of a wiggle in the private sector. So I think, honestly, to say that, the public sector, this is the reality. This is where we have 85% of the population. So I think, like what is happening in Zimbabwe, we've got an issue of healthcare delay. So this patient was seen 3 times, back pain at the clinic, HB of 9.6, and the indices were suggestive of iron deficiency. Patient was treated with iron deficiency as an outpatient on oral iron. So usually, also we've got a problem with with access to results. Time taken for the results. We don't have these tests in our setting, so we have to send these patients the test to South Africa. It takes us quite a lot of time for us to get an answer. So usually that's where the albumin and protein differential is important. And our imaging, we still use skeletal survey, which is very important, because if one has got an albumin and protein differential that is very significant, and skeletal survey is showing lytic lesions, usually we start these patients on on steroids, and then we whilst we are waiting for the results. We don't have we've got limited access to whole body MRI. One has to motivate, no PET scan, both in private and government. So this patient was from Katima, missed doses. Patient bus is full. He was deemed fit because the patient was walking. So it is the enrolled nurses who are checking whether the patient is sick or not. So if the patient is walking, the patient is fine, and patient was let's prioritize. So the patient had an early relapse with limited therapeutic options plus no transplant option. So this is just to talk about the lab services that are available in state, private, and not available also in the state sector and private sector. So the specific tests that we have, we've got only immunoglobulin tests. These are the usual, to check for immune paresis. These are the tests that we do. So usually what we do is we see an albumin protein differential, you send for immunoglobulin test because you can get that quickly, and then you check for immunoparesis, and then you wait for a few days for a paraprotein, serum free light chain, and a beta-2 microglobulin. So in the both private and public sector, we don't have this. We usually send this to South Africa. The only caveat here is that in the private sector, these tests, they spend about 2 to 3 days to come back. But in the public sector, one can wait for 1 week, 2 weeks. And if it is a public holiday, it's a problem, or the sample is lost. And I think you know the story, what happens with samples when they are moving from one place to the next. Right. So in the public sector, unfortunately, currently now we don't have someone who can read the bone marrow. So we don't have bone marrow. You can't do a bone marrow. You send to Lancet, and it takes weeks. And we don't have cytogenetics. We don't have flow cytometry. So these are the challenges that we are getting. But it's not all doom and gloom. So what are the future directions? So I think we just need to go back to the basics, like what our colleagues in Zimbabwe have shown us. First of all, we need to find these patients. So what we are doing is we are trying to do healthcare, and patient awareness education to prevent diagnostic delay. As you know very well, diagnostic delay is a two-part. You've got the patient delay, and then you've got the healthcare delay. And also the clinicians play an important role. Also, to promote interest in hematology, we need manpower. Advocacy. It's also important. We'll try and see if we can offer bone marrow transplant program, especially in the public sector with limited options. I mean, this is a powerful tool, and to improve hemato-oncology program in the country. And also to consider tandem transplant. We know that currently tandem transplant is falling by the wayside. But I mean, in our situation where we've got only cyclophosphamide and dexamethasone, I mean, tandem transplant becomes an important part in our armamentarium to try and treat these patients. And also to collaborate, and also, all these things, funding for conferences by partners, for healthcare workers, especially, the medical officers, because it's very important that we create interest. And I think sending them to conference really helps a lot to create interest, to try and seed the interest. Collaboration with the myeloma working group, the setting up of databases. So just to summarize, I've given you a situational analysis, multiple myeloma in Namibia, practical contextual experience both in private and public sector, and future directions and plan of action. So I am done, and I don't know if there are any questions. Hello.
We are all here, Simba. I think they are. Let's see. Moses has a question. Great.
No, it's not a question. I think it's a comment. I can see that there are quite a lot of similarities between our setting and Simba's setting. And definitely I can confirm that the three main points that he had said there, especially if we are going to improve the diagnosis of these patients, so we need to find the patients and we need to diagnose those patients, and advocacy is very important to make sure that we get these patients. Well done, Simba.
Wow. It would be great to hear from our other centers, if they just agree with the same type of experience, or if things are, if they have a different way that to address. I would be lovely to know if there's somebody from other universities, from Barra or from UKZN. If there's anybody who wants to give their input, or any of the other speakers, any other opinions, also from the lab side, from our people in the heme lab or other labs, the pathology lab, anatopath or other labs. Is there any ideas how to make it work? Remember, we do have a working party, a multiple myeloma working party. So
Hi, Stel. It's Charlene.
Sorry that I didn't see you. I don't know how. There you are.
It's just a little comment I want to make. This is something that obviously troubles me as well, because our patients do get to us quite late in many instances, and you're investing more money in trying to salvage them. Whereas if they had come sooner, perhaps outcomes may be better. And, I think a lot of work has to be done at the level of the district hospitals, and even some of the the regional hospitals where patients are actually missed. They're seen by the orthopedic surgeons. I mean, the case we presented this weekend as well was a case in point where the patient had an entire nail put into there, or a hip replacement, or whatever that was, and the myeloma diagnosis was made after that. So I think we need to create awareness at the level of at medical school, even during internship, basics of actually interpreting blood results, and as you so rightly said, how do you then direct your testing? Obviously, there's gatekeeping with tests to try and cut costs, but in patients where there is a need to further test, I think that should be done. Obviously, there should be blanket testing on every patient, but the guidance should be sought. And I think we make ourselves available in our province to whoever needs assistance in guiding a workup of a patient. It's just though getting the patients early. I think that's the crux of trying to solve this problem in my eyes. But how we do it is take some it's going to take some work. But I mean, for instance, my vision now is actually we have started that eco outreach at UKZN, and I think for this year my outreach is actually to try and reach out to the younger doctors and just guide them on hematological conditions. That's the most I can do, because we're a vast province with few hematologists. But at least if these recordings can be made as teaching material for these doctors in internship and comm service, and helping them interpret at least basic blood results. So that's just my comment, Estelle. And thank you for the wonderful work that's being done in them and Namibia. We really do reach out. I mean, I do feel for your challenges, but you guys are doing a wonderful job, and keep on going.
And we must do it together. That's all I know. It has to be done together. And we're all in this together. And the patients really need very clear, very simple points to be given to their doctors. It must be really compassionate and clear. We don't want to use any healthcare dollars that's not supposed to be for hematological malignancies. I think we're not fighting against other diagnoses, we're fighting for best diagnoses. And I think that's the nice thing. We can do it, that there's simple and clear things, like, for example, back pain. And, that back pain is not just back pain. I mean, that is a very simple aspect, that somebody who says, oh, I've been doing too much back work, that at least that person should at some stage get some testing or an X-ray that is at least that they know what to do if they see something strange in it. It's very difficult. I agree that you can't overdiagnose. Overdiagnosis is not going to happen, but you don't want to overtest. So it doesn't need a lot of input, where we help each other, and we may have some bright idea of how to speak better to our colleagues, and that we can share with the rest of the country and the rest of the continent. So, not sure.
I do have one comment.
Oh, that's great. Good.
Hi, sorry, I'm on my phone, so I couldn't figure out how to put the hand up. I just want to say well done to all the speakers. I think those were really excellent presentations. And despite what then eventually happened to your patients, and I think it's a clear example of the fact that, simple drugs like cyclodex are actually very helpful. And it speaks to the fact that the work that everyone's doing to try and get the message out there that early diagnosis is so important is critical. And you can already see it in Zimbabwe, where you've already got people more inclined to refer patients, although they're being referred late. Because I think the more the work carries on and the voices are louder, I think the better in the long run. Because I mean, these are young, relatively young, economically active people who don't need to be, fractured and this kind now anyway. So yeah, just well done to everybody, and thank you for that advocacy.
Thank you, Gamu, and thank you for all your bright ideas. There is lots that we're going to do together. I think we should let our audience enjoy their Monday afternoon in their private
one
spaces.
question, Estelle.
One question. Perfect. Do you have a final remark? Sorry, is there a question? Oh, sorry, I missed that one.
It's a question. No, I just wanted to ask, in terms of one of the things that is causing, the most common cause of mortality in our center is the renal impairment issue. I don't know how you guys are tackling it out. Do you have such good relationship or such good support from your renal units to dialyze some of these patients that present quite late? And what may we do from our perspective?
Who are you?
I remember at Bara, Prof. Patel wanted us to have a unit, a renal, a dialysis machine in our hematology unit. I don't know whether there's anyone from Bara who can say if that finally happened.
we can see if there's somebody. I didn't, for some reason, I can't go through and see who is in the meeting, but I think Cecile will have a very balanced opinion on it. I could, if Cecile, you know, I from my side, and I think Cecile, I think that, and that is not to minimize the late diagnoses. These people are just as precious. And they are paving the way for people to get proper diagnosis. But I do not think that our biggest need is dialysis. I don't know what Cecile wants to say.
Yeah, no, I agree totally. I mean, if we must certainly, and I know you feel strongly about it, Estelle, also concentrate on adequate fluid replacement right from the beginning. Start steroids early. Be careful not to give bisphosphonates too early. And you can often get patients, well, maybe not back to baseline, but back to a better renal function. Our dialysis department very seldom, if ever, support us, but we do have a number of patients, if the kidneys are not too badly impaired, that we can achieve something basically with fluids and steroids. So dialysis, I don't think, is our most important requirement at all.
Yeah, I think Moses, I think there's nobody from WITS that's speaking up from their side, but you know, we are trying to, and this is, I'm very serious about this. We want to carve out better diagnosis and treatment for all our cancer patients, all of them. And I think we must show that we can compassionately palliate those who are very advanced without a big fuss. And we must show that we can actually cure or at least really prolong life with our treatments without breaking the bank, because I do believe we have a responsibility to the rest of the country. You know, we must make hematology treatment and cure shine. I strongly feel that we should not be the people caring for everything, just not stopping anywhere. And I do agree with Cecile, lots of fluid. Remember, these people need liters of fluid. And I have found that that's much better the last few years after we've started to speak to our colleagues and explain to them, don't give Lasix. Do not give Lasix. Because what happens is people believe that Lasix is good for hypercalcemia. Then they write up 1 liter fluid every 8 hours and 80 milligram of Lasix. And guess what the sisters give? Can we all guess? We don't have to have a poll. We know what the sisters will give. Which one of the two? The wrong one.
Yes.
So we shouldn't, no bisphosphonates, no Lasix, tons of fluid, and sit next to the bed and see if your patient still has ability to produce urine. You know, do that for the patient. Ensure that but what happens is people abandon them when they come in or give them Lasix, or we definitely have a much better, I think, Cecile, in our hospital, our colleagues now know from medicine that we don't think, we say there is 4 to 6 liter deficit in these patients before they can get any kind of drug. You know, they must first be filled up, and then we can start giving drugs. And the first thing I would give is steroids. The first thing. I think that's the most important thing, because it stops the process.
Yeah, absolutely. I just want to add, and I agree absolutely with Estelle about, you know, that there are situations where it's palliation from the beginning. If there's irreversible renal failure, obviously in the state sector, dialysis support would never be offered. In our private sector, it is sometimes offered, and we've seen patients breaking the bank and breaking their families by trying to get dialysis. But even in the best countries, the statistics for transplanting in renal failure, transplanting on dialysis has very poor outcomes with less than 1 year long-term survival. So once a patient needs long-term dialysis, it's not a prospect for South Africa, certainly not for the state.
Yeah, so the outcomes are very poor. You can see how strong in Moses's data that Lloyd shared, the strong, I think it was Gilta, the very, very strong prognostic parameter that renal failure was, and that's worldwide. Worldwide, we know that renal failure is super, super important. Jacques, final word to you. And I'm going to say goodbye. So when we have finished your discussion, then we all know that we can say goodbye to each other. So let's hear it.
No, I just wanted to add on the, I mean, the issue of starting steroids early. I think apart from bortezomib early, pulse dexamethasone early has been shown to significantly improve renal function. So we often, if we are referred from one of our secondary hospital, a patient with a clear or likely diagnosis of myeloma, they start that before we even see the patient, we let them start the pulsed steroid. So I think that's really important.
Fluid.
Yeah, it's fluid. Yeah, of course. Yeah, the fluid. We never. Yeah, I mean, they should. We never give them Lasix until you know that they are full. So it's some basic clinical acumen. There's teach the students to assess fluid status. But yeah, and just to mention, our renal unit does acutely support patients, even if they don't. I mean, if they've got acute indications for dialysis, just to give them that chance. Maybe you do gain some return of function. Yeah, and I just wanted to, we don't have to discuss it now, but I was very interested over the weekend, Philippe Moreau and Meral Beksa comment on the use of fresh or even bone marrow harvested stem cells as a way to bring down cost in auto transplant. I think that's maybe something, I don't know if anybody's got experience with that in South Africa, but we can discuss that at another time, because could potentially be a significant cost saver if one can implement something like that.
An interesting idea for Windhoek, and also obviously for Harare. It's an interesting idea. But the other thing, just want to say one thing, if these patients do have to come down to a center anywhere in South Africa, these patients don't have to be hospitalized all the time. They can simply, get their harvest, which way you do it, because remember, marrow harvest is not easy in South Africa, but that's a different story. They can get their harvest, they can be in for 1 day, 2 days to get their chemo and their stem cells. They can go out for 7 days, and they can come back for 5 to 7 days. So in the end, it is not so unaffordable. There's wonderful NGOs that care for our patients outside of hospital, and they will definitely be willing, I think, to care for countries nearby. So I don't know about this fresh harvesting. That also will need lots of rigor. It's just my opinion. It's not so simple. So either you do the fresh harvesting in these countries and you just develop your own program, which I think is a brilliant idea, or you send them for visits in South Africa that doesn't cost so much, where we really, cut costs and shave the costs and make sure that it's not just lots of admissions and lots of inpatient stay, but short and sweet. I don't know, Jacques, Moses, Simba. I'm not speaking of your private patients, Simba. I'm speaking of the public patients.
I think for me that's very important, because even in the private sector, the issue is, just trying to make a feel to see the issue of bone marrow transplant. I mean, the issue that comes to fore is always the cost. People hear bone marrow transplant, the medical aids, they start shaking that, look, now here comes another cost again after COVID-19. So so these are some of the things that we can, discuss with them, that look, this is information that is coming in, that is new, that look, a patient can, infuse, and then after 3-4 days, once the counts are dropping, then the patient comes in and thermometer checks, 3 times a day and stuff like that and everything. And, and we try and see how it goes, because, the issue is, especially in our setting, even in private, if you look at how, if you look at the drugs that are being used in Europe, quadruple therapy, maybe we will be having 5 pentaplet therapy or whatever that is going to happen. For us, probably the highest that we can go is, VCD, probably. You can push it to, to other, for us, it depends if it is, the private medical aids, then they're like, we can't. Kafuzomib is like Cafezomepom Dex is like 600,000, 700,000. It's quite expensive. So I feel like, look, this is one thing, and transplant, I think, is there to stay. I think it's there to stay, especially in our African setting, because it really gives us a chance to really, kick the can down the road. So I feel like we are still far away. I mean, questions are there in Europe and America, but for us, transplant is there to stay, and we need to be innovative, look for ways to cut costs, like what is being said. Unfortunately, I was not there at the conference, but I think if there's anyone with articles looking at cutting costs, please, can you send them to me, because it's very important that we do that.
We can help you with that, and there's the myeloma working group where we can actually give people jobs to do. I see there's a last the situation with Indian generics and Zimbabwe and Namibia from Jacques. That's a great idea. And he says our patients from Lesotho all access bortezomib len from India. So another brilliant idea.
The problem in Namibia is that you see, NMRC is just the same as South Africa. Things are almost the same. So we are stuck here, unless if the patient has to get it, smuggle it and stuff like that. But we can, but it can be a bit of a challenge. But I think it's something to explore. I'll also have a look at it and see how we can try and see whether we can get these generics in this country, and because at the end of the day, the patients are benefiting. But I don't know the issue of proprietary rights and stuff like that, like in South Africa. I think we have to look at that.
Good. Let's see each other at the next multiple myeloma working group meeting, and let's take this further. We can have a committee on that and let's get some results, some answers. It was great to spend time with a Southern African group this afternoon. Have a lovely afternoon, and thank you to all the speakers. Wonderful. Thank you, thank you. Brilliant talks, thank you.
Thank you. Bye-bye.
Thank you.